it. Question and answers. So just a reminder, if you're asking questions, we are audio recording this, so we're going to post the presentation. Separately, we're going to post the Q&A. So just so you know, when you ask a question, we are recording it. If it's a highly private question that you want to ask, you can just grab us quickly after. And just a reminder, as Rob said, today the focus is not policy questions for the ministry. If you have those, you can just direct them into the ministry. We're here to talk about how we can support you, what the needs are that you think we and other people in the Central Program of Supports can meet. So questions, comments, experiences to share. Carrie, do you have any that have come in so far?
Sorry, I have two. The first one is probably a good one for Rob, I think. How should a team go about better defining their priority population?
Yeah, that's an excellent question, and it really is trying to look to see what the segments of that overall population are that you can actually feasibly manage in a first or second year. So the first one is really looking at where the opportunities are to move the triple aim or the quadruple aim. Where are opportunities to reduce hallway medicine, reduce overall costs, improve patient experience, and so forth? Okay, where are those opportunities? The second is really around where do you have all the right partners at the table? If you've selected, for instance, palliative care as a particular issue, and you don't have all the palliative care partners in the room, that you might need to go out and seek them. Okay. Third is really thinking really about feasibility here. It's about we built the trusting relationships over time? Do we have the leadership infrastructure in place? Do we actually can actually move the needle on the size of the population that we're actually thinking about? So it takes some real thinking about what those subpopulations would be, and where I've seen TerraHealth teams actually make substantial progress is where they actually look at a variety of different types of populations. They rank them by all those things that I talked about, and then they make their selections based on those ranking criteria as to where to start. But it really, I couldn't stress enough about the importance of the softer side of implementation in terms of leadership, relationships, trust, and feasibility.
I'm just moving to the other slide where we talked about populations here. Carrie. Oh, and sorry, before I forget, when you want to speak, for the folks that are in the room, you push it, and then if a number of you push it at the same time, when you're next up, yours will flash, and when it's on full red, your mic is working.
So this question speaks to, John, the slide you were previously on. Does a focus on the rostered patients at primary care not risk creating further barriers to access to care for marginalized populations, such who struggle to access primary and acute care, such as homeless, mentally ill, substance users, or newcomers? Yeah,
no, it's a great point. I think what we're struggling with the attributed population is helping teams take the first step. So Rob has emphasized before the importance of equity, so I think that's a point very, very well taken. This slide is perhaps about a slightly different issue, and we need to try to figure out how do we do both. This slide is about many teams put forward a geographic focus. I'm going to focus on the city of X. And then what's going to happen for teams that have been invited to full application is they're getting a map saying, actually the way that patients move around, a lot of your patients come from an area that's beyond what you've said, whereas patients in another part of your community are mostly getting care somewhere else. And so teams are having to figure out, well, what do we do now? So they're having to adjust to what that new platform is. So the first step is just think about what you were originally planning, and then whether it would make sense to now make adjustments to that given what you will eventually find out about referral and utilization patterns. And then the second thing is that the ministry is not providing to teams then a list of the names of all the people or the OHIP card numbers for all the people that are attributed to them. So teams are saying, but how do I start? Like, I know who lives in my community, but I don't know all the people that are coming into the community from other places, and some people who live here might actually seek care in other places. So what do I do when I don't know the list? So here our advice was, look, if you focus initially on the rostered population, you're going to get at least 4/5 of the population. So don't sweat the small stuff to get going in year one. Start with that population to get traction. But point taken, you also have to be very attentive to equity. And so depending on what you've chosen to focus on in year one, you might have other ways of identifying relevant populations. So if you're focused on homeless, marginally housed people, you're focused on people with severe and persistent mental illness, you might have to say, well, that approach won't work, so we're going to do some complementary stuff to make sure that we're reaching that group. Do you have anything to add?
No, I think that we just have to think practically around how to continually expand the populations and really make sure that you really practically think about getting the care models in place and then including people with additional complexity and issues as you think through this. There's no one-size-fits-all approach to it. But even within rostered populations, I would challenge the group to think that there are substantial socioeconomic issues within rostered populations that you can actually start thinking about how to address those populations around in-reach and outreach services to reduce the barriers of care for those populations.
Great. Was there a hand up here, the person right behind Carrie? Yeah, can you just turn your mic on?
Sorry,
Was it on this
actually
point?
along those same, I had a similar question along those
Okay.
lines. Yeah, thanks.
Okay, great. Other questions? Yes, yep. It should go on, just be patient with it. No? Can you try, would you be willing to try the one beside you? It's just, we won't, there's about 40 people online who won't hear you if we can't get a mic working. You're just in a bad row. Oh, there we go. Sorry about that.
So I do have a couple of questions.
Sure.
My first is with regards to legal issues. I didn't see anything about legal briefing about privacy laws, especially if we are looking at different touch points within the value chain.
Yeah.
So I'd like to know maybe more, possible?
You'd
More
like to know what was...
information. So more information. As
Yep.
we're designing these teams
Yep.
and our partners, so for example with population health, right? So if somebody goes to a lab, can they pull up and say, okay, while you're waiting, you didn't get your mammogram, right? These are the things that I'm looking at. I'm wondering if there's privacy laws, anything like that,
Yep.
that you can actually add.
Yep. Well, I'll just answer briefly, but Rob lives in that world probably more than I do. But typically, most of the partners sitting around the data have access to a certain set of data. And one of the early steps that everybody needs to go through are data sharing agreements that allow them to share across all the partners in the team. So that's going to be something that's a priority up front in order to allow this type of thing to happen. But Rob, you probably have a lot of experience.
I think everybody is struggling a little bit with this whole notion right now, and everybody is trying to figure out how we're going to work through this. My suggestion is there is, I believe, a digital health strategy coming out from the ministry in not too much longer that will provide a little bit of guidance on this area. But I think the ministry is actually open if Ontario health teams are facing barriers, particularly around legislative or regulatory barriers. I think the option is to actually try to figure out how we solve those problems. And so the ministry is absolutely open to hearing about the problems that Ontario health teams are trying to face in a whole variety of areas around regulation and legislation that may be able to figure out some path forward. But this is an area that I would actually suggest that you talk directly with the ministry about.
And I'm just pointing out the last principle on this slide. It's the first of the two on principles. It's identify the rules that need to get changed to get things right. So the ministry has signaled we're all ears. What is getting in the way of you providing the types of optimal care that we're talking about here? So if you think that's a problem, as Rob said, write to the ministry. Yeah, you had a second question or comment?
I guess my other question is about accountability.
Yep.
So when we're designing this, I thought the primary care physician was going to be accountable for the results, but that's not the case, correct? If you can just clarify that.
Yeah, well, I think it's a shared accountability. So if I go back to the collaborative governance, we're all, like, one way to think about it is we're all a bit of a part of the problem currently in why seamless integrated care isn't getting to the people who need them, and we all need to be part of a solution. So this model is about saying, how do we establish a collective accountability, and our roles as individual providers or individual organizations is to be clear about what our accountability is to the collective and to achieving the goal. So if I'm a single primary care physician, I'm hopefully going to do A, B, and C, and in exchange, my patients are going to have access to all of these other things happening, but we all have to agree to row in the same direction. So we need to think about what is our accountability to the broader group, and at the end of the day, to meet the quadruple aim metrics. So I think that's how we're now thinking about accountability.
Yeah, I think that's a really good way to think about it, is that there's gives and takes from everybody in this system. We all have to come in this together in terms of understanding how we're going to be held jointly accountable for those quadruple aims in our region. At the end of the day, it is the community, it is the people you serve in the community that you need to be accountable for. This is the population that you're serving, and at the end of the day, it's important that they're meeting their needs in terms of experience and outcomes to meet that. And it means everybody has to be rowing in the same direction. It's not the hospital's fault. It's not the primary care doctor's fault. It's not home care's fault. It's all of our fault if that's actually not working.
Did you have any other questions or comments?
I think I'm good.
You're okay? Yeah. Okay. Other questions or comments in the room, and then we'll go back to WebEx. Yes, sorry. Yep.
I'm thinking ahead to September when the teams in development are going to receive the output of the multi-specialty provider networks, like the MAPs, and just thinking of how this output will compare to a traditional MAP,
yep,
and sort of how we can start to prepare for the reconciliation of that output to the border we drew on the initial self-assessment.
Yeah, so it's a challenge. I mean, think about it's even more anxiety-inducing for the teams invited to full application because the number of weeks have already gone by and they don't have the maps yet, and October 9th is looking close. They've been told to expect them between August 19th and the 30th, so they're coming. So the good news is for you, it seems like a long way off, but you're going to get your maps. And then you're right, that's why, on that slide we say you're going to have to then step back and say, okay, what does this mean? So we thought it was this, and now we realize it looks a bit more like this, and how are we going to accommodate that? Who do we need to start speaking to, and so on? And this is incremental. Like, we keep hearing, and in a way it's new to hear this, from government. They're really open to figuring out how do we make this work. So we talk often about co-design when it's co-design with patients, but we're all co-designing this. We're figuring out how can this work, how can that work, and you're being given the flexibility to co-design in ways that make sense for your community. So I wish the maps could get on your table sooner because it's going to have implications for partnership, but as soon as you get them, you have to start that reflection about what does it mean for our partners and our next steps.
Yeah, thinking about attributed populations is a real different thing than thinking about geographic populations. So it's going to have to think in a different way about that. A couple things that might be helpful. Just remember that the attributed populations that the ministry has collected is actually reflective of prior patterns of care, prior choices that patients have made around where they want to seek their care, and prior relationships that physicians and other providers have with each other. And part of the OHT plan is to respect some of those long-standing relationships between patients and their primary care physicians, and those physicians with other physicians, so that we don't disrupt. Because again, if John, go back to that original comment, the trust is so important in this that we really don't want to start backwards. We want to respect the trusting relationships that are already in place.
One other thing, I mean, it's far from optimal in a way, but if you go back to the original ICES paper by Therese and Rick, you can actually see the maps there and get a pretty good sense, because the message from Therese and Rick is they haven't changed all that much. They'll give you at least a rough outline, but you actually need the current map to get the precision that you'll ultimately want. Yep. someone else might be earlier in the queue.
Oh,
There we go.
Sorry, I think it's me.
Okay.
I'm wondering if you could comment any more about these innovative models and how they relate to specialized services concept. So I think the innovative models were another entity that was introduced with this first round, and the idea of specialization. So how do those either connect or not, and what are these innovative models and what's the future for them?
Yeah, the short answer is I don't entirely know what direction they're going to go in, but you can see what the list of 9 are on the ministry website and get a feel for the types of things, but they're often, those assets that are more kind of provincial and regional, because we're going to have to, in Ontario, work out what's the intersection between the things that are local, that make sense for teams, versus the things that are, that have regional and provincial foci. So the challenge here is let those people kind of noodle through it for a while, and then we'll see what the implications are for OHTs and for these innovative models. That's how I've read it.
Yeah, and just to go back, specialized services and highly specialized services are really important in communities because you have a few people that really need them, right? And I don't think we want each community to try to invent different care pathways for those highly specialized populations that could be supported by regional. So we actually have to develop more cross-OHT work in those areas. That's, I believe, where the provincial supports are. It's to provide provincial assets to OHTs that can be helpful. Again, they have to intersect with OHTs. They can't be working in competition with them. That's going to be an evolution is actually how that works.
Question?
Oh, I was hoping you could share a bit more about how the maps are developed and what data that's based on. From what you've said so far, I feel like it might be OHIP data, but I'm in the mental health sector and a lot of clients would not be using an OHIP card to access those services.
You should have been on the attribution webinar yesterday. They went through in breathtaking
Okay, so I
detail.
can
No.
go back.
I mean, but if you want the particular methods, by and large, they're 95% exactly the same as the original paper that Therese wrote, which is on our website. So if you go to the All Resources webpage and you click on that first building block, define patient population, it'll open up and it'll bring you to a hyperlink to the paper, and all the methods are described there. And what the ministry has done is updated the application of those methods with more recent data. But I don't know that they've made any major departures. Are you aware of any?
I think you're right in many respects, and I don't want to get too far out of it because it's I want to make sure that I'm respectful of what's actually the ICS people have done, but they're clearly using current data that is available, that we know about what the patterns of care are through the system that is provided already. There are missing data in there. There's clear that there's not all the data to be able to attribute to every different provider, and there are certain select populations, and one of them is the uninsured population, or the ones that don't have OHIP. They're very hard to track. They're very hard to attribute. I think that's a challenge that all OHTs are going to have to face in the next while, is actually how we're going to deal with that population. Because at the end of the day, hospitals and providers are accountable for those populations that live in their communities. They incur costs, they incur care pathways, and we actually have to figure out how to capture them.
Karen?
So very similar question. For health centers that do not roster patients, how do we track their referral and utilization patterns?
Yeah, well, there's the challenge, if the approach had been geographic, so let's say we're going to take the city of Hamilton, it's easier in some respects, more difficult in others, but it's easier in some respects. With this model of an attributed population, in the short run, you're not going to know who those individuals are. So that's why we've suggested saying start with the rostered patients, because at least they're defined. Most of what drives the attribution is your connection to a primary care physician. So 82% of Ontarians are rostered currently. So that's going to vary by community, but on average, 4 out of every 5 patients are going to be attributed based on who they are rostered with. So that's why we suggest starting there. But then over time, you can deduce others who are attributed to you by their primary care pattern. So if it turns out, I don't have a rostered practice, but I have a certain number of patients who come in regularly for care, they're going to end up rostered to the team that I am linked to. So that can get you a long way towards knowing who they are. I think both Rob and I think in the long run, it's likely to be the case that it will be helpful for teams to have an algorithm that they can run using data that the team will have access to in order to more precisely identify who those people are. The ministry's determination of attribution will always have a time lag element to it, but teams are going to want to know in something closer to real time. But that's a few years off. What matters now is taking incremental steps that are population in focus. And that's what Rob keeps reminding us. We have to start thinking about populations. We're not going to be at 100% on day one, but 82% is a big improvement. If we were to ask for proactive support to those 82%, it's transformative, but we need to get to 100. We just won't get there in year one.
I think this is an area that we're going to have to spend some time thinking about it, but I don't want to lose the forest for the trees. We actually do know a lot about who we serve in our hospitals, in our primary care sectors, and in our populations. I work at Trillium Health Partners in Mississauga, and I pretty well know that the people that are close to Mississauga will use that hospital, right, for their care if they need it. And I know that even among the family physicians in that vicinity, they use the specialists of our hospital for the majority of the patients that they'll see. So we already know a good segment of that population that we're accountable for. But now it actually is about thinking through the accountability for that population in itself. So I don't think we should get too hung up on this at the moment. It's really thinking about the population health management strategy going forward.
Other questions from the room? Other questions online?
There's one, but I think it's largely addressed to the previous question, but I'll pose it just in case. How are OHTs going to help all the people who are in communities that can't currently get primary care physicians?
Yeah. Do you have anything? This is all about taking incremental steps to do better. And I think that right now, no one really bears accountability for those individuals. And now it's going to be much clearer that it is a group of organizations that have come together as a team that have to crack that nut. And different communities are going to crack the nut in different ways, and they're going to need to be appropriate to the local context, but at least this change is helping us to put our thinking in that direction of being accountable for those people and starting to figure out how do we connect them into a primary care system that's working well.
Yeah, I think there's natural incentives that start actually being built into this now. The more that we connect care providers in communities like this, one of the big problems right now in hospitals is overcapacity with hallway medicine. And I shudder to think right now in our hospital in Mississauga how many people are actually receiving care in hallways. And actually they didn't receive many of them didn't receive adequate primary care to begin with, right? So there is actually incentives now to actually work with communities, making sure that patients get rostered, making sure that they have accountabilities in primary care, making sure that the capacity is there in the community to kind of alleviate some of the hospital problems. But this is going to be an experiment around actually how to do this and how to actually have that thinking take place. It is about shared accountability for this, and it's a shared accountability for not only the people that you're seeing and walking in the door, but also the people that aren't.
Any final questions before we wrap up? Final questions online? No? So last call before we wrap up. And otherwise, if you have questions you want to ask us one-on-one, just come to the front. So if not, I just encourage you to check out the website, point your colleagues toward it. If you have needs that you feel aren't currently